This is a 6-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. This talk is about upper GI cancer. It's the final part of 4 on this topic. It covers post-operative survival and Barrett's esophagus. The speaker is Francis Hughes, upper GI surgeon and lead clinician for upper GI cancer MDT at Barts Health NHS Trust.
So the 1-year survival after esophagectomy is, in our hands, approximately 85%. I would be aiming for all patients who undergo esophagectomy to be alive at 2 years, but it's by the 2 years drops to about 70%, and that's because of metastases that were not identified on the initial scans, and inevitably there will be some of those. 5-year survival is approximately 50%. This is just to compare 5-year survival in the various centres. Some data from America, Australia. We do slightly better than that, and we are in parallel with the other big unit in London at St Thomas's. So Barrett's esophagus then is very common, affects approximately 1.5% of the population. If you take everybody that comes to endoscopy, you will identify 1.5% of all patients who undergo endoscopy will have Barrett's esophagus. If you take all the patients with reflux, then 12% of those will have Barrett's. And the risk of adenocarcinoma in patients with Barrett's is about 40 times that of the general population. Barrett's esophagus seems to be more common in the United Kingdom than the USA. We're not entirely sure why that is. It's commonest in middle-aged men, but it can occur at any age, and in fact the youngest I have treated was 5 years old, so you do get it in children. So what are the things that drive the malignant progression? Continued gastroesophageal reflux. In particular, bile reflux is thought to be important. So your proton pump inhibitors are going to control the acid reflux, but proton pump inhibitors are not particularly good at controlling bile reflux. So that in young patients, particularly if they have had a family member who has gone on to develop esophageal cancer, it may be worth considering anti-reflux surgery. Obesity, more common in obese patients with Barrett's to develop adenocarcinoma. Moderate wine is supposedly protective, but that's always a difficult one, I'm sure, to advise people on. Genetics, if a family member has had Barrett's esophagus then and progressed to cancer, then it's much more likely in the offspring. So the management of Barrett's esophagus depends on whether there is any evidence of dysplasia or not. Non-dysplastic Barrett's esophagus then just continues on endoscopic surveillance, and the recommended surveillance protocol is every 2 years, taking 4-quadrant biopsies over the length of the Barrett's. Once the patient has developed dysplasia, if it's low grade, then they just require more intensive surveillance. But if they have high grade dysplasia, 50% of patients with high grade dysplasia in Barrett's esophagus will have an undiagnosed cancer. And so, and if you look at that more carefully, in patients with an ulcer and high-grade dysplasia, then 90% of those will have a cancer. So high-grade dysplasia needs intervention. And a couple of years ago, what we would have said was that anybody with high-grade dysplasia should have esophagectomy. There are new techniques coming through now where we are using endoscopic resection of an area of dysplastic Barrett's. If you can see a macroscopic abnormality that can be removed endoscopically, and then ablation of the remaining Barrett's esophagus using various techniques, but at the London we're moving towards radiofrequency ablation of the remaining Barrett's. At the moment, radiofrequency ablation is quite carefully regulated, and there's a national register. We are as yet unsure of the long-term results.
That concludes this webcast on upper GI cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.